So some of my slides are crowded. I didn't talk with my colleagues up here today about what I was going to talk about, but I was that Dr. Brown asked me about this. So for your all consideration, sickness is best regarded as semantic networks, that is culturally articulated systems that interrelate cognitive categories, personal experiences, physiological states, and social relationships. Healing, from that perspective, involves the same semantic networks. So dry eye is actually a semantic network of sorts, okay? It's not just one thing, it's a collection of all those things, okay? And we're here because of that semantic and interpersonal network. Arthur Kleinman was a professor, he's an anthropologist, and he talks about the role of healing sickness, you know, witch doctors. It's important to name a disease. When you are suffering, you like to know the name of what you have, because then it stops being an abstract suffering. And dry eye disease is what many people are labeled with having, and they feel good because now they have a name, except that I don't think that's a great name for what they're suffering, because it takes people in the wrong or it takes people up garden paths. And then finally, for the researcher, the disease-illness dichotomy, the disease is the thing we see and treat. The illness is what the patient is suffering from. And that dichotomy creates a special difficulty. Which aspect of the sickness does he or she, again, this was 1980, and he wasn't woke yet, and so it was only he's. What aspect of sickness do they study? When they evaluate outcome, is it the curing of disease? Have your meibomian glands gone up from 22 to 24? Have your Schirmers gone up 2 numbers? What does that mean? Do you have less SPK? Or is it the healing of illness? Or is it both? And this is why we're here, to kind of figure this out and address this. And I wish I had more opportunity to share these thoughts and for people to think about them. So now I'm going to share with you some of my clinical pearls, and I can be a little controversial and a little outspoken sometimes, but here I am. I don't believe that patients fundamentally complain of dry eye. Dry eye is what doctors have told them they have. Just because the eyes feel better temporarily with lubricant drops does not mean that the eyes are dry. It might mean the nerves are hypersensitive and you're shielding them a little. The lubricant drops treat the symptoms but do not cure disease. Typical symptoms of dry eye, we know this, we're fluent in this room: grittiness, irritation, foreign body sensation, tearing, burning. Typical signs, old school, we look for staining. When the symptoms match the signs, and we call that SPK or PEE, most of you, how many in this room have read their own medical notes and had to decipher the abbreviations? A lot of you, so you know what these things are, right? There can be an injection and redness. One of the speakers said the redness was the thing that bothered her a lot about her eyes. And then there's no signs. People whose eyes look fine, that's a large fraction of people in this room. We used to call this keratoconjunctivitis sicca in the 50s, 60s, 70s, and 80s. Then we got more woke. We stopped using Latin terms. We need to use real language. It was called dry eye syndrome because we understood that the itis means inflammatory, sicca means dry, and not all the people who showed up with this were inflamed or were dry, so we called it dry eye syndrome, dry eye disease. There was a term dysfunctional tear syndrome for people who were symptomatic but seemed to have normal tears, and people thought there was something, a chemical that was wrong in the tear film. So that was a phrase used. Anybody here been told they have dysfunctional tear syndrome, or has that fallen out of favor? That term was used a bit. And now what I think we should call it, ocular surface disease. The ocular surface includes all these structures. It's a fully integrated functional unit of great importance to vision and health. The tear film is in there. It's considered a structure. In 2007, there was a wonderful thing, the dry eye workshop. I didn't attend because I was kind of new in the field. I was at Boston site, but I wasn't established enough really to be part of this, but I was very excited when it came out because finally someone who was paying attention to these patients, and there was an attempt to schematize ocular surface disease. And then there was dry eye disease on the left. There was something called prodromal states. That was a little nod that there were people with symptoms who maybe didn't fit into this anywhere, but I don't know what that is. Then there was what was called non-dry eye disease, and an interesting little tidbit, MGD is down there under non-dry eye disease. So this was a way of, and then other OSD, allergy, infection, post-refractive is other OSD. I mean, it was just the beginning of an awareness. 10 years later, this is DEWS 2. And it's not gotten better, sadly. It's gotten worse. When you convene 200 people and try to get an overarching system, you get a lot of input. There's a lot here to process. There was a lot of industry support, and I like industry. I worked with various players. I appreciate that they're here and supporting us. I appreciate they supported Dry Eye 1, DEWS 1 and DEWS 2, because it gets people together and thinking and talking. But unfortunately, all the arrows just simply point to aqueous deficient versus evaporative. And other things are cast aside, like refer for pain management, offer education. I don't know. I'm not excited about this. So I wish I could say there was progress. There definitely was progress, being more players to the table, but I'm not sure it helps us managing individual patients. This is also DEWS 2. A whole bunch of stuff going on at the beginning, triaging questions, risk factor analysis, diagnostic tests get a big box. Then you go into your subtype classification, and then the step therapy. Those are the lines as you go from severity of, again, binary division, evaporative severity, and aqueous deficient severity. Maybe I believe that ocular surface disease is non-binary. That's my new line, that it's not just aqueous deficient or evaporative, that it's non-binary. I'll just leave it there. I do want to go back to our model, because this is where we all got started. Sjogren disease is a paradigmatic model for dry and ocular surface disease described in 1933. It was recognized as a systemic autoimmune disease that showed up dry eye, dry mouth, and inflammatory infiltration of the glands. That is where the term keratoconjunctivitis sicca came up. That's where you see these terrible end-stage findings, and it's relatively rare, but it was hard to treat, and it was the rationale for the development of immunomodulators for dry eye. So who in the room knows what the first drug for dry eye was? Restasis, right. Restasis was welcomed with open arms because we had nothing to offer people with immune-based dry eye. And it took a long time to get it approved, in part because in the first study, the vehicle control, the thing they dissolved the Restasis in, had as much benefit as the drug, okay? So they had to go back to the drawing board at Allergan and do some more testing and find other ways to measure. But it did get approved. It entered the market. By then, there was an awareness that people with symptoms, not necessarily Sjogren's, but symptoms of ocular surface or dry eye disease had very high prevalence. And so when Restasis hit the market, it was a blockbuster. It was a mic buster, right? And because we had nothing to offer people and it had a broad indication. My own experience, though, is it's useful only in a small fraction of people who have symptoms, but I do push it on people who I believe have immune-based dry eye. Another drug came out, Exidra, in 2016, but this is big bucks and big opportunity for industry because there are a lot of people suffering. How many of them have immune-based dry eye? Still an unanswered question. The stepwise therapy was devised by this consensus, and they say that you should go stepwise through the treatments for dry eye disease, and many of you have been subject to this, and I don't really adhere to it. Step one, this was meant to make everybody happy, and so the least invasive things come first, and the most invasive things come last. There's a realm of practice scope that optometrists have. They can't go to the most invasive range, but they want to be offering a lot of good treatments. There's a workforce issue. There aren't enough MDs, and MDs who are ophthalmologists who could do the invasive things, they're not interested. They'd rather do cataracts, cornea transplants, the glamorous stuff. So instead we have this stepwise approach, which I don't like, honestly, but it's what's out there. It's deuce two. First steps are considered the benign things, lubricants and lid hygiene of various types. If those are inadequate, and this is the meat of treatment, there's all kinds of things. Treat for Demodex, if present, punctal occlusion, moisture chamber goggles. That should be up there in the first box. That's a no-brainer to me. I am thrilled to see so many people in this room. You guys are the believers who have them on. You wouldn't believe the fraction of patients I see who've seen other dry eye doctors who've never heard about moisture chamber spectacles. And I teach that to my trainees. And it costs less than I mean, they're not cheap if you have a pair of 7 eyes or whatever. But so there's no prioritization here, and this is a challenge. As far as what to do first and in what order, but they're all listed here. And then these are the more invasive things, which are put off at the end. Oral secretagogues, those almost never help. I'm not sure why they're on here. They're a rare helper. And then the lenses, serum tears, and then the things that are considered high risk or harder to administer. But honestly, I use topical corticosteroids, and I do permanent punctal occlusion all the time. The question is how to manage it. But it's not a quick in and out thing. So my story with this is that patients don't complain of dry eye. Dry eye is what doctors told them they have. The stepwise or stepladder therapy is good for clinicians, especially if MDs are delegating or deferring to ODs who have a narrower scope of practice. It's very good for industry, but it's not as good for patients. It can be inefficient, it can be expensive, and I wish as a group we could do better. The alternative is to treat by symptoms. I have published an algorithm on this. It's not going to be widely adopted, but it summarizes my patient-centered approach, and I ask about their primary complaint, or I see what they tell me it is. Intermittent blurry vision, I address one set of things. Gritty, sandy sensation, another. Burning, another clue. Itching, tearing, and then at the bottom, contact lens discomfort. That's what people show up with. And these are the ways to deal with them more specifically. And this is initial treatment. Most of this can be done whether you're MD or OD. I think it's a more valuable approach. Another alternative is to treat by the disease category: aqueous deficient, limbal stem cell deficiency. My friend here with the mid-face issue, he had corneal exposure, leg ophthalmos. That wasn't recognized from the get-go. And that could, yes, the surgery cured it, but there would have been ways to treat it if it were recognized. And I look at lid closure on every single patient before I even get to the meibomian glands, and these guys do too. Neurotrophic keratitis, congenital anesthesia, epidermal disorders, contact lens intolerance, its own category, that's a separate entree into the system, separate approach. Dry eye syndrome, that's nociceptive pain, but no stain, one set of treatments. And then ocular neuropathic pain, also no stain. Could be peripheral, nociplastic, or central, different set of treatments. My summary, lumping all together is the basis for stepwise or stepladder treatment. It's a big market for whatever's being sold. If 70% of the people who go on Restasis fail, it still means a huge number of people are on it for a short amount of time. Big bucks, okay? It's worth trying, but it's not appropriate to try for someone with contact lens discomfort. It's not an appropriate starting point. It's the easiest one, it's what they get, but it's really not appropriate. So as I said, stepwise, stepladder approach is easier for docs, good for industry, but specific approach for symptoms and for each type of ocular surface disease is better for patients. Thank you.